Hi all, my name is Dr. Yang. Today's topic will be basic concept of occlusion and Andrew Seed's keys of occlusion, and also including IOTN, or the full name is Index of Orthodontic Treatment Needs. This is the learning outcomes. By the end of the lecture, you should know how to define occlusion, myocclusion, and concepts of normal occlusion. You also need to know how to classify the different types of myocclusion, its advantages and disadvantages. You must also know how to outline the type of cups, and you should know how to list down the Andrew Seed's keys for normal occlusion. So, what is the meaning of occlusion? So, based on Dolan Medical Dictionary, occlusion is the relationship of the maxillary and mandibular teeth when they are in functional contact during activity of the mandible. Occlusion is vital for all branches of dentistry, and the purpose of this lecture is to present orthodontically oriented concept of occlusion. So why we call this orthodontically oriented concept? Why not dentistry oriented concept or others? This is because in some books they define occlusion based on the branch of dentistry. So later when you have some more further reading, you will see there is some difference between orthodontically oriented concept and prosthodontically oriented concept. So in this lecture, we will only focus on orthodontically oriented concept of occlusion. Okay, another meaning of occlusion by Edward Engel is occlusion is the normal relation of the occlusal inclined planes of the teeth when the jaw are closed. These are the terminologies used in occlusion. First, ideal occlusion. What is ideal occlusion? Ideal occlusion is the concept of ideal or optimal occlusion refers both to an aesthetic and physiological ideal. It includes functional harmony, stability of masticatory system, and neuromuscular harmony. Secondly is the physiology occlusion. This occlusion shows no sign of occlusion-related pathosis, such as traumatic occlusion or crossbite. It may not be an ideal occlusion, but there will be no other pathological manifestation in the surrounding tissue, such as ulcer or gingival recession. Next one is balance occlusion. This is an occlusion in which balance and equal contacts are maintained throughout the entire arch during all excursion of the mandible, meaning that both upper and lower teeth will maintain a good contact when the mandible is moved laterally or anterior posteriorly. That is what we call balance occlusion. The fourth one is a functional occlusion. It is defined as an arrangement of teeth which will provide the highest efficiency during all the excursive movement of the mandible which are necessary during function. The key word for this definition is the highest efficiency. And then the next one is a therapeutic occlusion. It is a treated occlusion employed to counteract structural interrelationship related to traumatic occlusion. Okay, now we can see that the first photo shows there is a crowding on the upper and lower arch. When we put on the braces and then we may do some extraction, the teeth are all aligned. This is what we call therapeutic occlusion, the teeth that have been treated by braces. Traumatic occlusion and trauma from occlusion more or less carries the same meaning. Traumatic occlusion is an occlusion judged to be causative factors in the formation of traumatic lesion of disturbance in the orofacial complex, whereas trauma from occlusion is defined as periodontal tissue injury caused by occlusal force through abnormal occlusal contacts. Sorry for the spelling mistake, it should be periodontal tissue injury. So in both photos, it shows that due to traumatic occlusion, the tissue injury is a gingival recession of the lower teeth. The next one is type of cups. There is two type of cups. First one is the supporting cups, and then the second one is the non-supporting cups. What is supporting cups? Is the facial cups of mandibular and palatal cups of the maxillary posterior teeth are called centric holding cups or supporting cups. Another name for it is stem cups. They occluded with the central fossae and marginal ridge of opposing teeth. The area of contact of the supporting cups with the opposing teeth in maximal closure should be well established and stable. The next one is non-supporting cups. What is non-supporting cups? It is the maxillary buccal and mandibular lingual cups are called non-supporting cups. They contact and guide the mandible during lateral excursion and shear foot during mastication. Hence, they are also called as shearing and guiding cups. So, in order to memorize what is the non-supporting cups, you have an acronym called BULL, which is buccal of upper and lingual of lower. So it's very simple, right? There are three types of imaginary occlusal curve, which is curve of Spee, which is also known as anteroposterior curve, curve of Wilson, which also known as mesiolateral curve, and curve of Monsoon. Curve of Monsoon is the combination of both curve of Spee and curve of Wilson. Now we will look into details what is curve of Spee. Curve of Spee was discovered by Mr. von Spee. This anteroposterior curve or curve of Spee was defined as the anatomical curve established by the occlusal alignment of the teeth as projected onto the median plane, beginning with the cusp tip of the mandibular canine and following the buccal cusp teeth of the premolar and molar teeth, continuing through the anterior border of the mandibular ramus and ending at the anterior aspect of the mandibular condyle. So you can see all this explanation in one red line on the picture of the skull. A flat to slightly concave curve of Spee bears the proper occlusal surface for optimal occlusion. The next one is curve of Wilson. It is a mesiolateral curve that contacts the buccal and lingual cusp teeth of the mandibular posterior teeth. It helps in two ways. Firstly, the teeth are aligned parallel to direction of medial pterygoid for optimal resistance to masticatory force. Secondly, the elevated buccal cups prevent food from going past the occlusal table. The third type of curve is curve of Monsoon. It is obtained by extension of the curve of Spee and curve of Wilson to all cusps and incisor edge. It forms a sphere of a 4-inch radius. Mandibular arch adopted itself to a curved segment of a sphere. So, based on the photo, we can see that there is a imaginary line that connects the cups so that it will form the curves, and also the 4-inch radius that's explained better about the curve of Monsoon. Now is the classification of occlusion. So occlusion can be classified into centric or eccentric, functional and non-functional, lateral or protrusive, canine guidance or group function. I will be explained one by one in the next slide. Firstly, the centric relation. What is centric relation? Is the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective teeth with the complex in the anterior superior position against the shape of the articular eminence. This is something very anatomical, and you need to know clearly where is the position of the anatomical part. Centric relation is a bone to bone relation. That's why it's really anatomy related. It is a muscle determined position and it is not influenced by teeth and occlusion. whereas centric occlusion is tooth-to-tooth relation and it is a tooth-determined position. Centric occlusion is that position of the mandibular condyle when the teeth are in maximum intercuspation. So the keyword is the maximum intercuspation. Centric occlusion is also called intercuspal position or convenient occlusion. Centric relation and centric occlusion should coincide in order to have perfect harmony between the teeth, the TMJ, and the neuromuscular system. Some studies have shown that majority of the population have a maximum intercuspation 1 to 2 mm forward of centric. So the occlusion is related to the position of the condyle. Centric contacts are areas of the teeth that contacts the opposing teeth. There are three types of centric contacts, which is the posterior, anterior, and poded. Posterior centric contacts consist of the facial range of contacts and the lingual range of contacts of the posterior teeth. The facial range of posterior centric contacts involve the mandibular facial cusp teeth contacting the central fossae and mesial marginal ridge of the opposing maxillary teeth. Lingual range of posterior centric contacts involve the maxillary lingual cusp teeth contacting the central fossae and distal marginal ridge of opposing mandibular teeth. Anterior centric contacts involving only the anterior teeth. Anterior teeth have only one range of centric contacts and are in line with the facial range of posterior centric contacts. The poded centric contacts. It is the centric contacts that often occurs on inclines of posterior teeth. The inclines or slope of the guiding cusps from the guiding cusp teeth toward the center of the tooth. These contacts that occur on inclines are called poded centric contacts. If the contact occurs on two inclines, the contact is termed as bipoded contact. On three inclines is termed tripoded contacts. On fourth incline is termed quadrupoded contact. Now we will look at eccentric occlusion. Any occlusion relation other than centric occlusion is called eccentric occlusion. Eccentric contacts refers to contacts of the teeth that occur during movement of the mandible. Eccentric occlusion can be divided into two types, which is one functional occlusion and then second one is non-functional occlusion. Functional occlusion, also called working side occlusion, refers to tooth contact that occur in the segment of the arch toward which the mandible moves. So when the mandible moves to the right side is called functional occlusion. So when the mandible moves to the left side and then the left side is called functional occlusion. Functional occlusion can be two types. The first one is lateral functional occlusion, which is from side to sides. And then the second one is protrusive functional occlusion, is when the mandible moves forward. For the lateral functional occlusion, it includes tooth contact that occur on canines and posterior teeth on the side to which the mandible moves. It can be divided into two. The first one is the canine guided occlusion. During lateral mandibular movement, the opposing upper and lower canine on the working side contact, thereby causing disocclusion of all posterior teeth on the working and balancing side. Canine guidance occlusion is usually seen in a young individual with unworn dentition. Secondly is the group function occlusion. In addition to canine guidance, certain other posterior teeth on the working side also contact during lateral movement of the mandible. In a periodontically weakened dentition, sometimes the posterior teeth, usually premolars, also come into contact during lateral movement of the mandible. For the group function occlusion, usually it happens in an older person because the canine is already worn, so that's why there is a contact on other posterior teeth, for example in canine, premolar, and sometimes in molars. For the protrusive functional occlusion, it includes eccentric contacts that occur when the mandible moves forward. Ideally, the six mandibular anterior teeth contact along the lingual incline of the maxillary anterior teeth, while the posteriors disocclude. For the non-functional occlusion, there are tooth contact that occurs in the segment away from which the mandible moves. For example, if the mandible is moved to the left side, contact occurs on the right side of the arch. Now we move to Andrew's case of optimal occlusion. This Andrew's case of optimal occlusion is invented by Dr. Lawrence Andrew. He collected 120 non-orthodontic models from 1960 to 1964, and from this model, he selected the study model who had never done any orthodontic treatment, and the teeth were straight and pleasing in appearance. And the study model also has a bite which look generally correct and will not benefit from orthodontic treatment. He then compared those 120 non-orthodontic models into 1,150 treated models. He studied the difference between best in treatment result versus best in nature, which gave birth to the 6 key of optimal occlusion. So now we will look one by one into 6 keys to optimal occlusion. Key number 1 is inter-arch relationship. This key consists of 7 points. The first one, the mesobuccal cups of permanent maxillary first molar occludes in the groove between the mesial and middle buccal cups of the permanent mandibular first molar as explained by angle. Second, the distal marginal ridge of the maxillary first molar occludes with the mesial marginal ridge of the mandibular second molar. Third, the mesiolingual cups of the maxillary first molar occludes in the central fossa of the mandibular first molar. Number 4. The buccal cups of the maxillary premolars have a cups embrasure relationship with the mandibular premolar. Number 5. The lingual cups of the maxillary premolars have a cups fossa relationship with the mandibular premolars. 6. The maxillary canine has a cups embrasure relationship with the mandibular canine and first premolar. The tip of its cups is slightly mesial to the embrasure. Finally, number 7. The maxillary incisors overlap the mandibular incisors and the midline of the arch match. Key number 2, mesiodistal crown angulation. The degree of crown tip is the angle between the long axis of the crown and a line drawn 90 degrees from occlusal plane. For the occlusion to be considered normal, the gingival part of the long axis of the crown must be distal to the occlusal part of the line. You can have a look on the picture at the side. It is called positive when the gingival portion is distal to the incisor portion, and it is called negative when gingival portion is mesial to the incisor portion. Key number 3, labiolingual crown inclination. The crown inclination is determined from a mesial or distal view formed by a line 90 degree to occlusal plane and a line tangent to bracket side. If the gingival area of the crown is more lingually placed than the occlusal area, it is referred to as positive crown inclination. In case the gingival area of the crown is more labially or buccally placed than the occlusal area, it is referred to as negative crown inclination. For the anterior crown inclination, the maxillary incisor and mandibular incisor shows a different inclination. For the maxillary incisor teeth, it shows a positive crown inclination, whereas for the mandibular incisor, it shows a very mild negative crown inclination. For the posterior crown inclination, the maxillary and mandibular posterior have a negative crown inclination. Key number 4, absence of rotation. The fourth key to normal occlusion is that the teeth should be free of rotation. If molars rotated, it will occupy more space than normal. Rotated incisor occupy less space in the arch, so it will create a situation unreceptive to normal occlusion. Key number 5, tight contact. To consider a occlusion as normal, there should be tight contact between adjacent teeth. So the teeth should be well aligned, and it should be no spaces between the teeth. So we can see the first photo is an ideal photo of occlusion, and the second photo is not ideal because there is spaces between the teeth. Key number 6, curve or sphere. The plane of occlusion found in the non-orthodontic models range from flat to slight curve or sphere. A flat plane should be treatment goal as there is natural tendency for the curve or sphere to deepen within time. So how do you know that the cases have a deep curve or sphere? So when we see the photo, the either one patient have a flat curve or sphere, and then patient will have average overbite. And the second one, the curve or sphere is not ideal, meaning that there is a deepening of the curve or sphere. In this case, when the teeth are in occlusion, that patient will have deep bite. So curve or sphere and deep bite and overbite, both are linked to each other. The last key is key number 7, correct tooth size. Bolton tooth size ratio is considered as 7 keys of occlusion, so that the tooth size of the maxillary and mandibular arch should match for the proper overjet and molar relation without any spacing or crowding. Bolton analysis is an analysis that the orthodontist will do prior to treatment to analyze tooth size discrepancy. The potential need for interproximal reduction to decrease tooth size in one arch or restorative procedure to increase tooth size in opposite arch should be considered with patient or parents before treatment. Do you realize that this is an additional key because the Andrew should only have 6 key to normal occlusion. So key number 7 is additional because it's also will help in getting a normal or good occlusion. Now we will move to our next subtopic, which is IOTN. This is a short form for the Index of Orthodontic Treatment Need. So why we must know about IOTN? IOTN is an index to measure the necessity of orthodontic treatment. It is widely used in all over the world. So it combines both functional and aesthetic measures, and it's used to assess the need and eligibility of children under 18 years of age for orthodontic treatment. So mainly in government clinic, we use this index, in order to screen for patient that is eligible for orthodontic treatment before we put on the waiting list. IOTN is an objective and reliable way for specialists to select those children who will benefit most from treatment, and is a fair way to prioritize limited resources. So it's very widely used in government clinic in Malaysia and all over the world. IOTN developed by Brooks and Shaw from University of Manchester, United Kingdom in 1989. The IOTN consists of two parts, which is dental health component or DHC and aesthetic component AC. For dental health component, it measures of any discrepancies in occlusion and give them a grade from 1 to 5, where 5 is the most severe. Grade number 1 shows that this patient does not need any orthodontic treatment. Grade number 2, patient may have little need of orthodontic treatment. Grade number 3, moderate need of orthodontic treatment. Grade number 4, great need of orthodontic treatment. And grade number 5, very great need of orthodontic treatment. For the aesthetic component, it consists of a set of 10 standard photographs which are also graded from score 1, which is the most aesthetically pleasing, to score 10. I will show you the photo later for aesthetic component. Now we will look at the dental health component. This table of dental health component using the MOCDO acronym to further prioritize different forms of malocclusion. So what is MOCDO? For the dental health component, they only look at a single worst features, and therefore they use the acronym MOCDO, which consists of M for missing teeth, O for overjet, C for crossbite, D for displacement of contact points, and O for overbite, including open bite. And then they were classified into 5 grades according to what I explained before, which is number 1, no need of orthodontic treatment, and grade 2, little need, grade 3, moderate need of orthodontic treatment, grade 4, great need of orthodontic treatment, and grade 5, very great need of orthodontic treatment. This is the photo of aesthetic component. As I explained before, it consists of a set of 10 standard colored photographs which are also graded from score 1, the most aesthetically pleasing, to score 10, the least aesthetically pleasing. So we can see photo number 1 and number 2, number 3 and 4 have no or slight need for treatment. However, in photo number 5, 6 and 7, we can see the teeth are quite crowded or they may have spacing, which indicates a moderate or borderline need of treatment. Whereas for the photo number 8, 9 and 10 has a greater need for orthodontic treatment. Now we will look at a dental health component and aesthetic component one by one. For the dental health component, grade number 1, it shows there is no need for treatment. So usually for grade 1, there will be extremely minor malocclusion including displacement less than 1 mm. So we can see that this photo, for the lower incisor teeth, there is a extremely mild crowding and the displacement is less than 1 mm. So we can see that the diastema also have less than 1 mm. It's very minor malocclusion. For grade number 2, little need for treatment, they have a few scoring for dental health component. They will have 2A, 2B, 2C, 2D, 2E, 2F, and 2G. So what is 2A? 2A is increased overjet, and then this is the range of the overjet is within 3.6 to 6 mm overjet with competent lips. 2B is reverse overjet, and then the reverse overjet is within 0.1 to 1 mm. 2C is anterior and posterior crossbite with 1 mm discrepancy. 2D is displacement of teeth within 1.1 to 2 mm. 2E is anterior and posterior open bite 1 to from 1.1 mm to 2 mm. 2F is increase over bite is around 3.5 mm or more without gingival contact. And 2G is half unit discrepancy in molar occlusion and on or super class 1 without any other malocclusion. So the uh, the numbering and then the alphabetical order that used within this grading is invented by Dr. Brock and Shaw himself. So during my master studies, we need to memorize all this. So the question will be, tell me what is 2D, then you need to explain what is 2D. Tell me what is 2A, then you need to explain what is 2A. So try your best to understand and memorize this. This is an example of grade 2A with increase of jet up to 6 mm. Noted that patient can still close the lips together. If patient unable to close the lip together or incompetent lips, the grading will increase to be 3A. This is 2B for the reverse overjet up to negative 1 mm. So we need to measure with the ruler. If the reverse overjet is more than negative 1 mm, and then the grading will increase. This is 2C, anterior or posterior crossbite within 1 mm discrepancy. So we can see that the crossbite is very minor. So that's why it's a little need for treatment. 2D, displacement of teeth up to 2 mm. So how do we measure displacement of teeth? Let us focus for the lower incisor crowding. So we can see that for the teeth, we need to measure from the contact point to the adjacent teeth contact point. So the displacement of the contact point should be less than 2 mm so that the grading will be 2D. If the displacement of contact point is more than 2 mm, the grading will be higher. This is 2E, the anterior or posterior open bite, up to 2 mm. In this photo, the anterior open bite is around 2 mm, so the grading will be 2E. And then this is 2F, increase over bite, around 3.5 mm or more without gingival contact, meaning there is no traumatic bite in this grading. Okay, so you need to measure properly for the overbite. This is 2G, half unit discrepancy in molar occlusion without any other malocclusion. So in this grading, the molar is in class 2 half unit, whereas the other teeth are well aligned and there is no crossbite, no increase overjet, and nothing else. Now we move on to grade 3, which is the moderate need for treatment. It consists of 3A, increase overjet up to 6 mm with incompetent lips. 3B, which is reverse overjet up to negative 3.5 mm. Next one is 3C, anterior or posterior crossbite with 1.1 mm to 2 mm discrepancy. And then 3D, displacement of teeth up to 4 mm. 3E, lateral or anterior open bite up to 4 mm. And 3F, increase or complete overbite without gingival trauma. Now we will look at this classification one by one. Yeah? This is 3A, increase overjet up to 6 mm. The main difference between 2A is for 3A, patient presented with incompetent lips. This is 3B, reverse overjet, up to negative 3.5 mm. So we can see from this photo the reverse overjet. The next one is 3C, is anterior or posterior crossbite with 1.1 to 2 mm discrepancy. As what we see in this photo is an anterior crossbite. 3D is displacement of teeth from 2.1 mm to 4 mm. So we can see from this photo, you should measure the displacement of contact point of the teeth. For example, for this photo, look at the contact point of the lateral incisor to the contact point of the central incisor. It's around 4 mm. So in this case, we classify the dental health component, the DHC, as 3D. This is 3E, which is lateral or anterior open bite, 2.1 mm to 4 mm. So this photo shows patient presented with anterior open bite up to 4 mm. This is 3F, increase or complete overbite without gingival trauma. So you need to see at the palatal side whether they have a trauma or not. Okay, now we move to grade 4, which is great need for treatment. 4A is increased overjet from 6 to 1 to 9 mm with incompetent lips. 4B is reverse overjet greater than 3.5 mm with no masticatory problem. 4C is anterior and posterior crossbite with greater than 2 mm discrepancy. 4D is severe displacement of teeth greater than 4 mm. 4E is extreme lateral and anterior open bite greater than 4 mm. 4F is complete overbite with gingival trauma. 4H, less extensive hypodontia requiring pre-restorative orthodontic space closure to obviate need for prosthesis. 4L is posterior lingual crossbite with no functional occlusal contact in one or both buccal segments. 4M is reverse overjet 1 to 1 to 3.5 mm with recorded masticatory and speech difficulties. 4T is partially erupted teeth, tip impacted against adjacent teeth, and 4X is supplemental teeth. So when you read more about grade 1, 2, 3, and 4, you can see there is a repetition of the alphabetical. So when we see if A, it will refers to overjet. If B is reverse overjet. And then for C is crossbite, D for displacement, E for open bite, and then F for overbite. So for grade 4, there is some new alphabetical, which is L for lingual crossbite, H for hypodontia, M for reverse overjet with masticatory problem, T for partially erupted teeth, tip or impacted against adjacent teeth, and X for supplemental teeth. For A, so A is for overjet. So in grade 4A, it refers to increased overjet from 6.1 to 9 mm with incompetent lips. So you need to measure the overjet so that you can know what is the DHC, the dental health component of this case. 4B is reverse overjet greater than 3.5 mm with no masticatory problem. Okay, so after this you will see there is 4M. 4M is for reverse overjet with masticatory problem. So you need to know how to differentiate the numbering of the grade. So B is for no masticatory problem. M if meaning with masticatory problem. This is for C. C is for crossbite. So it's anterior and posterior crossbite with greater than 2 mm discrepancy. Okay, so you can see clearly in this photo. The, the next one is 4E, is extreme lateral or anterior open bite greater than 4 mm. So you can see clearly in this photo we have anterior open bite which is greater than 4 mm. Okay, 4F is for complete overbite with gingival trauma. 4H is H for hypodontia, requiring pre-restorative orthodontic space closure to avert need for prosthesis. So in this photo, you can see patient has missing laterals. 4L is posterior crossbite with no functional occlusal contact in one or both buccal segment. So you can see clearly in this photo on the one side there is no occlusal contact at all. 4M, okay, is different from 4B just now. 4M is reverse overjet 1.1 to 3.5 mm with masticatory and speech difficulty. This is 4T, partially erupted teeth, tip and impacted against adjacent teeth. This is very easy. 4T is only in grade 4. Another one is 4X, supplemental teeth. You can see in this photo, patient has one extra lateral incisor. Okay. Now we will move to grade 5. Very great need for treatment. So patient who have a dental health component in grade 5 really need orthodontic treatment. Okay, 5A is increase overjet greater than 9 mm. 5H, okay, just now you see 4H, now is 5H, meaning extensive hypodontia, which is more than one tooth missing in any quadrant, requiring pre-restorative orthodontics. 5I, this is only special for grade 5. We don't have 4I, 3I, 2I, we just have 5I. So this is impeded eruption of teeth due to crowding, displacement, presence of supernumerary teeth and retained deciduous and others except impeded eruption of third molar. So we also have 5M, which is reverse overjet greater than 3.5 mm with masticatory and speech difficulty. So just now 4M is lesser than 3.55 mm. 5M is reverse overjet greater than 3.5 mm. Okay, 5P. 5P is very special. Once you see patient with a cleft lip and palate, definitely is 5P. Another one is 5S, submerged deciduous teeth. So this is very special. When you see submerged deciduous teeth, is definitely 5S. So by now, I think you can really relate grade 1 to grade 5. Some of them there is a repetition and some of them is very unique at their own grading. Now we look at grade 5A. DHC 5A, sorry, is an increase overjet greater than 9 mm. 5H is extensive hypodontia with more than one tooth missing in any quadrant, requiring pre-restorative orthodontics. So you look at this photo, patient has more than one missing tooth in the same quadrant. Okay. 5I is impeded eruption of teeth due to crowding, displacement, presence of supernumerary teeth, retained deciduous, and others. So especially in impacted canine, once you see impacted canine, definitely is 5I. 5M is reverse overjet greater than 3.5 mm with masticatory and speech difficulty. Definitely in this photo, patient requiring orthodontic surgery and patient cannot bite properly, and then patient also cannot say some words properly. So patient definitely will have masticatory and speech difficulty. The next one is 5P, defect of cleft lip and palate. It can clearly be seen in this photo. This is 5S, which is submerged deciduous teeth. This is very easy. Once you see patient presented with submerged deciduous teeth, definitely the dental health component is 5S. Okay, as a recap for IOTN. So you need to know IOTN there is two parts. First is dental health component. The grading is from grade 1 to grade 5, and we have some repetition uh, of the occlusion. For example, the overjet, usually we use A, 2A, 3A, 4A, and 5A. Reverse overjet, there is B. And then for the crossbite, 2C, 3C, 4C. Okay, that is dental health component. Another component is aesthetic component. So you can refer to the previous slide. The aesthetic component is presented with a 10 standard photograph which graded from score 1. Score 1 is the most aesthetically pleasing to score 10. The score 10 is the least aesthetically pleasing. So what is the relation between DHC and AC? So usually an average score is taken from these two components. But in clinic setting, the dental health component alone is more widely used. The aesthetic component, there is some limitation because it's being very subjective. You can see at the aesthetic component is only class 1 myocclusion and class 2 myocclusion is available, but there is no class 3 myocclusion or anterior open bite seen on the photograph. So this is the limitation of aesthetic component. So basically, when you graduated from BDS and you start doing practicals in the clinics, uh, you can use IOTN for screening of orthodontic patient, and you can present the patient with dental health component and as well as the aesthetic component in your report. Okay, now uh, we reach the final two slides. So the learning outcomes. So at this point, you should know how to define occlusion, malocclusion, and concept of normal occlusion. You should also know how to classify the different types of malocclusion, its advantages and disadvantages, and you should also know how to outline the type of cups, and also you need to know how to list down the Andrew skills for normal occlusion. Okay, this is some textbooks that I can suggest you for further reading. So basically, I think for me personally, I like to read Introduction to Orthodontics by Laura Mitchell. I think it's suitable for you for BDS level. And then if you want to have more knowledge in orthodontics, you can read Handbook of Orthodontics. And Contemporary Orthodontics by William Profit actually is a master level. And then Orthodontic at a glance is, I think, is better for final revision when you already know all the basic things. So for me, I recommend you Introduction to Orthodontics by Laura Mitchell. Okay, for now, there is the end of my lecture. If you have any question, you can email me at my email, rafida@pidc.edu.my. So for this, thank you for your attention and have a nice day. Bye.